So there is something called as a megaloblastic anemia, and as well as non-megaloblastic anemia in the macrocytic anemias. Macrocytic anemias are characterized by large erythrocytes. Large erythrocytes means MCV more than 100 femtoliter with an increased MCH and a normal hemoglobin content. Okay, so how do you define actually the macrocytic anemia is macrocytic anemia is MCV more than 100 femtoliter, increased MCH but normal MCHC. That means cell will be very big, and MCH will be very high, but concentration is normal. Percentage of how much it is occupying. So suppose this is central pallor, how much percent it is occupying is normal, but how much is the hemoglobin, that can be increased, and how much is the size, that can be increased, that is increased. This is an important group of anemias because macrocytosis is frequently a sign of disease process that can result in a significant morbidity if left untreated. Macrocytosis is found in 2.5 to 4.5% of the adults who have a routine complete blood count. In up to 60% of the cases, macrocytosis is not accompanied by anemia, but isolated macrocytosis should always be investigated. Macrocytosis without anemia. Macrocytosis without anemia can indicate early folate cobalamin deficiency. So if there is a macrocytosis and there is no anemia, that means something is cooking up. What is cooking up? Megaloblastic anemia is cooking up. Because macrocytosis precedes the development of anemia in these disorders. First macrocytosis will come, then anemia will come. Macrocytosis detected by automated cell counter is not always apparent microscopically on sustained blood smears. In some cases, the erythrocyte size on automated counters is falsely elevated due to the hyperglycemia, cold agglutinin, and extreme leukocytosis. These causes of false microcytosis need to be differentiated from true macrocytosis. The most common cause of true macrocytosis is alcoholism. So alcoholism is the most common cause of macrocytosis. How do you remember? When these people will consume the alcohol, they will talk bigger words. These drunk people, they will talk big words. So that's how you can remember macrocytosis in alcoholism. Other causes include folate and cobalamin deficiency, drugs including the chemotherapy, reticulocytosis due to the hemolysis, bleeding, myelodysplasia, liver disease, hypothyroidism also can cause big RBCs. Macrocytic anemia are generally classified as a megaloblastic and non-megaloblastic, that is normoblastic, depending on the morphological characteristic of erythroid precursors in the bone marrow. Megaloblastic anemias are the result of a defect in the DNA synthesis. There is DNA, right? Because of the defect of a DNA synthesis, there are big blasts, megaloblasts. Frequently, there is an arrest in the S phase. S phase arrest is there. No, S phase arrest is there, and DNA synthesis defect is there. And to a lesser extent during other phases of cell cycle due to delayed nuclear development, RNA and protein synthesis, however, are relatively unimpaired. The result is unbalanced cell growth and impaired cell division characterized by erythroblasts with distinct abnormal morphological features. The nucleus appears immature with a fine particulate chromatin pattern, whereas the cytoplasm is increased and relatively more mature, referred to as nuclear cytoplasmic asynchrony. These cells are referred to morphologically as a megaloblastic. All proliferating cells are affected. The basis for the non-megaloblastic anemia is not always as well defined, but is often related to an increase in membrane lipids. Membrane lipids, when they are increased, then big cells will be seen in the peripheral smears. This is all about lipids. When there is increase in the membrane lipids. But in megaloblastic anemia, they are oval. A flowchart for laboratory analysis to help the distinguishes causes macrocytic anemia is shown in this figure 15.2. We will discuss later here. So first you will see HB is less but MCV is high. Then you will go for the reticulocyte count. If it is normal, then it is normal or low, that is 0 to 2%. You will see macroovalocytes, dacrocysts, Howell jolly bodies, hypersegmentation. So these are the features when the reticulocyte count is normal or low. When reticulocyte count is very increased, this bleeding, hemolysis, response to the therapy for anemia that can be suspected. If there are like reticulocyte is normal and in the peripheral smear, when you see the cells, there are Howell jolly bodies, hypersegmented neutrophils, macroovalocytes, then you have to go for a serum cobalamin assay. If there are no such cells in the peripheral smear, then round macrocytes you have to see. Suspect normoblastic macrocytic anemia, liver disease, alcoholism, aplastic anemia are the causes for normoblastic macrocytic anemia. Macrocytes are not there means consider false increase in the MCV due to the cold agglutinin and hyperglycemia. The conditions associated with the megaloblastic and non-megaloblastic, that is normoblastic macrocytic anemia are: first one, megaloblastic anemia, folate deficiency, cobalamin deficiency, as you know, and there are other causes. In folate deficiency, there can be nutritional deficiency, increased requirement as in the pregnancy, intestinal. Okay, so today I have seen one case where I'll just show it to you here. Let me show you where it is. Okay. I have seen today one hypersegmented neutrophil here. Very hypersegmented. See, this is the real case that I have seen today. So here if you can observe, there is 1, 2, 3, 4, 5, 6, 7, hopefully this is 8th lobe of neutrophil is there. That you call it as approximately more than 7 lobes of neutrophils are there. This is in a 22-year female patient who is having who is reported as a normocytic normochromic blood picture, as well as there is a neutrophilic leukocytosis. She is a pregnant lady who is G2P1 L0A1 patient. That means this is her first pregnancy, but the last pregnancy was there is abortion happened. So this is her first pregnancy, and there are no other no other abnormalities in this patient. So as I am reading now this McKenzie, so here they have mentioned increased requirement in the pregnancy can cause the folate deficiency, that in turn cause the megaloblastic anemia, that will show as hypersegmented neutrophils in the blood smear. So that may be the cause. Now I can relate the this theory. Intestinal malabsorption can cause the folate deficiency, drug inhibition can cause the folate deficiency. Now cobalamin deficiency is same, like small bowel resection. Pernicious anemia can cause the cobalamin deficiency, gastrectomy, intestinal malabsorption, here also intestinal malabsorption, nitrous oxide abuse, these laughing gas, maybe this is called as laughing gas, I'm not sure. So nitric oxide, when it is abused a lot, then B12 deficiency can occur, then there are megaloblastic anemia can occur. Megaloblastic anemia can occur because of nitrous oxide abuse, transcobalamin deficiency, increased requirement as in the pregnancy, nutritional deficiency. So these are the causes of cobalamin deficiency. Chemotherapy, orotic aciduria, congenital dyserythropoietic anemia. So these are the causes of megaloblastic anemia. Normoblastic anemia, normoblastic macrocytic anemia, that means above cell erythroblast is a normoblast, and then it will go give rise to the macrocyte. Whenever it is forming a blood cell, it was normoblast, but when it came into the circulation, it has become bigger. That's how, at least how I can remember. So this is called as a macrocytic normoblastic macrocytic anemia. Here it was already megaloblast, then it has given still same macrocyte. So this is, we call it as a megaloblastic anemia. That's how I remember, at least. Might not be the real meaning of it. So normoblastic macrocytic anemia is caused in the alcoholism, liver disease, shift reticulocytosis, there is increased in reticulocyte count, hemolytic anemia, hemorrhage, hypothyroidism, aplastic anemia, obstructive jaundice, splenectomy, pregnancy, artifacts like hyperglycemia, cold agglutinin, leukocytosis. In these cases, you will get the normoblastic macrocytic anemia. At least you remember this. Alcoholism associated with the liver disease, that is done. Liver is done, right? Liver is done. Now we will go to the spleen. So splenectomy is done. Then along with the liver, obstructive jaundice. Then coming to the thyroid hypothyroidism. So that way you can remember normoblastic macrocytic anemia. Megaloblastic anemia, coming to the megaloblastic anemia. Although very little was known about the function or origin of blood cells before the 20th century, some perceptive individuals began to make associations between anemia and other clinical signs patient. S.S. Coombe, a Scottish physician, made the initial clinical description of the patient who appeared to have a megaloblastic anemia. He was the first to suggest that the anemia might be related to the dyspepsia. Then after Coombe, Thomas Edison reported his description of macrocytic anemia, but he made no reference to the typical microscopic blood findings. The discovery and description of the abnormal erythroid precursors in the bone marrow associated with this anemia were made possible by advent of triacidic stains. Paul Ehrlich, first came the Coombe, next came the Thomas Edison, now the Paul Ehrlich is credited with the coining the term megaloblast in 1891 to describe the large abnormal precursor in megaloblastic anemia. That is by Paul Ehrlich. So first was Coombe, first was our who was that guy? Coombe, Thomas Edison, next Paul Ehrlich. Megaloblastic anemia is classified as a nuclear maturation defect. It is Nuclear maturation defect. Anemia is attributed primarily to a large degree of inactive erythropoiesis resulting from disrupted DNA synthesis. Ineffective erythropoiesis resulting from the disrupted DNA synthesis. The anemia was called megaloblastic in an attempt to describe the giant abnormal appearing erythroid precursor, that is megaloblast, in the bone marrow. The generic word megaloblast describes any maturation stage of megaloblastic erythroid series. Polychromatic megaloblast. The generic word megaloblast describes any maturation stage of the megaloblastic erythroid series, mainly polychromatic megaloblast. Other nucleated cells of the marrow are also typically abnormal. About 95% of the megaloblastic anemia are caused by the deficiency of the vitamin B12, that is cobalamin, or a folic acid vitamin necessary as coenzymes for nucleic acid synthesis. In the majority of the cases, cobalamin deficiency is secondary to the deficiency of an intrinsic factor, a protein necessary for the absorption of the cobalamin, rather than a nutritional deficiency of the vitamin. Folic acid deficiency, on the other hand, is most often due to an inadequate dietary intake. Inherited disorder affecting DNA synthesis or vitamin metabolism are rare causes of megaloblastosis. This is the peripheral blood smear of the patient with the pernicious anemia. Note that there is anisocytosis, there is difference in sizes. So you can see this anisocytosis with oval macrocytes. There are oval macrocytes and the nucleated red blood cell with Howell-Jolly bodies. This is the peripheral blood film from the patient with normoblastic macrocytic anemia. Normoblastic macrocytes are there. Normoblastic macrocytic anemia. Compare the size of the RBCs with the lymphocytes. You know, this is the lymphocyte and this is the RBC. Big RBC, more than the size of the nucleus of the lymphocyte. The onset of megaloblastic anemia is usually insidious because the anemia develops slowly. It produces a few symptoms until the hemoglobin and hematocrits are significantly depressed. Patient can present with typical anemia symptoms of lethargy, weakness, yellow or a waxy pallor. Dyspeptic symptoms are common. Glossitis with a beefy red tongue, or more commonly a smooth pale tongue is characteristic. Loss of weight and loss of appetite are complaints in pernicious anemia. Atrophy of the gastric parietal cells cause decreased secretion of the intrinsic factor and hydrochloric acid. Bouts of diarrhea can result from the epithelial damages in the gastrointestinal tract. Neurological disturbances only in the cobalamin deficiency, not in the folic deficiency. They are most serious, dangerous clinical signs because neurological damage can be permanent if the deficiency is not treated promptly. The patient's initial complaints occasionally are related to the neurological dysfunctions rather than the anemia. Neurological damage has been reported to occur even before the anemia or macrocytosis in some cases. Particularly in elderly people, the bone marrow, however, usually reveals megaloblastic changes even in the absence of anemia. The bone marrow, however, usually reveals megaloblastic changes even in the absence of anemia. Tingling, numbness, weakness of extremities reflect peripheral neuropathy. Loss of vibratory position, sensation in the lower extremities can cause the patient to have an abnormal gait. The patient's relatives sometimes note mental disturbances such as loss of memory, depression and irritability. Megaloblastic madness is term used to describe severe psychotic manifestations of cobalamin deficiency. A patient with a severe anemia occasionally is asymptomatic, which is probably a reflection of very slowly developing anemia. It has been suggested that cobalamin deficiency should be suspected in all the patients who have an unexplained anemia and or neurological disturbances, or in individuals who are at the risk of developing a deficiency, such as elderly people and intestinal disease people. So what happens is this megaloblastic anemia, whatever we are calling it as, so this megaloblastic anemia takes a very long period to develop, and when it develops, it affects mainly neurological system. Okay, neurological system. So whenever in the slide you see hypersegmented neutrophils, there are big macrocytes, so many big macrocytes. So then you have to ask the patient whether the neurological symptoms are there or not there. So in that way you can think about the megaloblastic anemia. Laboratory findings, laboratory tests are critical to a diagnosis of megaloblastic anemia. The routine CBC with a review of blood smear gives important diagnostic clues, helps in selecting the reflex test. Peripheral blood megaloblastic anemia is typically a macrocytic normochromic anemia. The MCV is usually more than 100, macrocytic normochromic more than 100, and can reach a volume of 140 femtoliter. However, in an increased MCV is not a specific for megaloblastic anemia. The MCH is increased because of the large cell volume, but the MCH is normal. In cobalamin deficiency, a macrocytosis can precede the development of anemia by months to years. On the other hand, MCV can remain within the reference interval. Epithelial changes in the gastrointestinal tract can cause iron absorption to be impaired. If an iron deficiency, which characteristically produces a microcytic hypochromic anemia, coexists with megaloblastic anemia, macrocytosis can be masked and the MCV can be normal. Suppose what they are telling is, suppose gastrointestinal tract, there is epithelial absorption is impaired. Okay, then what happens? Obviously there is a megaloblastic anemia happens. Along with that, iron deficiency can occur. So in iron deficiency we have microcytic hypochromic anemia, but in megaloblastic anemia we have big cells macrocytic anemia. So both together compensate and MCV can be normal. Other conditions that have been shown to coexist with the megaloblastic anemia in the absence of increased MCV include thalassemia, chronic renal insufficiency, and chronic inflammation or infection. Sometimes these coexisting causes of anemia are not recognized until after the megaloblastic anemia has been treated. It has been suggested that if coexisting iron deficiency, thalassemia, chronic disease is suspected, patient medical history and previous MCV should be considered. Hematologic parameters vary considerably. The hemoglobin and erythrocyte count range from the normal to very low. The erythrocyte count is occasionally less than 1:10 raised to 12 per liter. However, anemia is not always evident. In one study, 100 patients with confirmed cobalamin deficiency, only 29% had an hemoglobin less than 12 grams. This is significant because the neurological symptoms can be present even if the MCV and hematocrit are normal. So there is, suppose if you have a patient who is neurologically very irritable and all, neurological symptoms are there, gait is not proper, in that patient it is admitted in the psychiatric ward. Now they will as usual send you to the CBC and you will do the CH. In the CBC everything is normal, no HB, nothing, NNBP. Okay, you give it as a NNBP, but when you are doing CH, in that slide you see there are there are hypersegmented neutrophils, big cells. So in this, even if there is anemia is not there, this vitamin B12 deficiency is affecting his neurological system. In this case you can give the B12 supplementation even if the anemia is not there. So that way this patient can improve in condition. Because the abnormality is nuclear maturation defect, the megaloblastic anemia affects all three blood cell lineage like erythrocytes, leukocytes, and platelets. This is unlike most other anemia that typically involve only erythrocytes. The leukocyte count can be decreased due to an absolute neutropenia. Platelets can also be decreased but do not usually fall below the 1 lakh. The relative reticulocyte count is usually normal. However, because of severe anemia, the corrected reticulocyte count is less than 2%. The absolute reticulocyte count is low. RPI is less than 2. The distinguishing feature of megaloblastic anemia on the stained blood smear include the triad of oval macrocytes will be there, Howell jolly bodies are there, hypersegmented neutrophils are there. So megaloblastic anemia, if you want to name it as a megaloblastic anemia, you have to see these features like oval macrocytes, Howell jolly bodies, and hypersegmented neutrophil. So if these are there, then you can call it as a megaloblastic anemia. Anisocytosis is moderate to marked with a normocytic and few microcytes in addition to the macrocytes. So here we see the differences between the non-megaloblastic macrocytosis and megaloblastic macrocytosis. WBC will be decreased, platelets will be decreased in the megaloblastic, RBC count is decreased, hemoglobin is decreased, hematocrit is decreased. Usually MCV is high, RBC morphology ovulocytes, Howell jolly bodies, polychromasia, hypersegmented neutrophils will be there. Reticulocytes is normal or decreased reticulocyte count, serum cobalamin will be decreased, folate will be decreased, Figlu is increased, and MMA is increased. Figlu is increased, MMA is increased, homocysteine is increased, serum bilirubin is increased, LD is increased. Every these enzymes are there, no, they are all increased in the megaloblastic anemia. However, in the non-megaloblastic macrocytic anemia, so RBC can be decreased, hemoglobin can be decreased because it is anemia. The MCV can be more than 100. Platelets can be normal, WBC can be normal, polychromasia, target cells, stomatocytes in liver disease, cystocytes in hemolytic anemia. If there are cystocytes are there, no cystocytes, then it is hemolytic anemia. If there is stomatocytes are there, no, then they are liver disease. Just remember, hypersegmented neutrophils will not be there. Reticulocyte count will be normal or increased or decreased, we can't tell. Serum is usually normal cobalamin, and all these enzymes, these are normal. Here is the hypersegmented neutrophils from the peripheral blood of a patient of the pernicious anemia 1, 2, 3, 4, 5, 6, 7, 8. So 1, 2, 3, 4, 5, 6, 7. And a few microcytes in addition to the macrocyte. Okay, this is done. Poikilocytosis can be striking and is usually more so when the anemia is severe. Polychromasia, chromatophilia, megaloblastic erythroblasts can be seen, especially when the anemia is severe, indicating the futile attempt of the bone marrow to increase the peripheral erythrocyte mass. Cabot ring usually can be seen in the erythrocytes. Granulocytes and platelets can also show the changes evident of abnormal hematopoiesis. Hypersegmented neutrophils can be found in a megaloblastic anemia even in the absence of the macrocytosis. Even if there is macrocytosis is not there, then hypersegmented neutrophils will be there. Finding 5% or more neutrophils with the 5 lobes or 1 neutrophil with 6 or more lobes is considered that a hypersegmented neutrophil. So more than or equals to 5 lobes in more than 5% of the which should be more than 5%, more than equals to 5 lobes in more than 5% neutrophils, that is, or more than equals to 6 lobes is called as a hypersegmented neutrophil. More than 5 lobes in more than 5%, more than or equals to 6 lobes, that is hypersegmented neutrophil. This finding of a hypersegmented neutrophils is considered highly sensitive, specific for a megaloblastic anemia. Therefore, hypersegmented neutrophils offer an important clue to the megaloblastic anemia in the face of coexisting disease that tends to keep erythrocyte volume less than 100 femtoliter. One study showed that in patients with a renal disease, iron deficiency, or a chronic disease with a normal or decreased MCV and 1% hypersegmented neutrophils, 94% had vitamin B12 folic acid deficiency. If 5% hypersegmented neutrophils were counted, the incidence of the B12 or a folic acid deficiency increased to 98%. So this hypersegmented neutrophils is very important, because B12 deficiency and folic acid deficiency, the accuracy will increase to 98%. Hypersegmented neutrophils tend to be larger than normal neutrophils. So hypersegmented neutrophils are so much larger. You can see in this. Okay, this is the real slide. So you can see here big neutrophil. Normal neutrophil will be, if it is like this, then this is very big one. Hypersegmented neutrophils tend to be larger than the normal neutrophils. A mild shift to left with the large hypogranular bands can also be noted. Mild shift to left will be there with the hypogranular bands. Platelets can be large platelets, especially when the platelet count is decreased. So let's study of the bone marrow. If physical examination, patient history and peripheral blood findings suggest megaloblastic anemia, a bone marrow examination can help establish a definitive diagnosis. In megaloblastic states, the bone marrow is hypercellular with megaloblastic erythroid precursor and decreased ME ratio. In a long standing anemia, red marrow can expand into the long bones. About half of the erythroid precursor typically show megaloblastic changes. Megaloblasts are large nucleated erythroid precursor that display nuclear cytoplasmic asynchrony with the nuclear maturation lagging behind cytoplasmic maturation. The nucleus of the megaloblast contain loose open chromatin that stain poorly. Cytoplasmic development continues in a normal fashion. Open chromatin, loose and open chromatin. At each stage of development, the cells contain more cytoplasm with a more mature appearance relative to the size and maturity of the nucleus. The megaloblastic features are more easily noted in a later stages of erythroid development. The megaloblastic features are more easily noted, as we have seen here. You can recollect here. I have marked it. Let me show you polychromatic megaloblast. So that's what they are saying. The generic word megaloblast describes any maturation stage of the megaloblastic erythroid series, that is polychromatic megaloblast. So here also they are telling that at each stage of development the cells contain more cytoplasm with a more mature appearance related to the size and maturity of the nucleus. The megaloblastic features are more easily noted in the later stage of erythroid development, especially at the polychromatophilic stage. At the polychromatophilic stage, this is the stage where perfectly megaloblastic features are noted, in which the presence of the hemoglobin mixed with the RNA, hemoglobin mixed with the RNA gives the cytoplasm the gray blue color. RNA mixed with the hemoglobin gives a gray blue color typical of this erythroid precursor. The polychromatophilic megaloblast nucleus, however, still has an open lacy chromatin pattern more typical of an earlier stage of development. Even it is progressed, like suppose this is erythroblast, like early erythroblast, that is pro-normoblast, whatever you say. So that when it has become polychromatophilic, the nucleus has to be more dense, right? So instead of that, because there is a DNA deficiency here, DNA maturation defect, nuclear maturation defect, so that's why what happens, nucleus will not mature, nucleus will not become condensed, it will be still open and lacy chromatin pattern more typical of an early stage of development. Leukocytes and platelets also show typical features of a nuclear maturation defect. They also show the nuclear maturation defect, it is at the blast level, so that's why they show you nuclear maturation defect, that is leukopoiesis and thrombopoiesis. Giant metamyelocytes will be there, bands with a loose and open chromatin is there. That means in megaloblastic usually what is happening is the nuclear maturation is lagging, so that's why what is nuclear related things are there in RBC as well as the WBC as well as in the platelets, so all will be one stage precursor to the mature thing, so all the precursor will be there. The myelocyte can show poor granulation as do more mature stages. Megakaryocytes can be decreased, normal or increased. Maturation, however, is distinctly abnormal. Larger than normal forms can be found with separation of nuclear lobes. Other laboratory findings. So before that, let me just say that other laboratory findings, if CBC results suggest megaloblastic anemia, further testing is necessary to distinguish the cause. If they are telling that it is a megaloblastic anemia, then what is the cause we have to see? What are the causes? Two causes are there, right? B12 deficiency and B9 deficiency. To see which one is deficient, we have to go for a further investigation. The common next step is to measure the serum cobalamin and serum red cell folate. Laboratory use different method, that is chemiluminescence radioassay, to measure the cobalamin. So there is no gold standard to use as a reference interval. Generally values less than 150 picogram per ml are consistent with the cobalamin deficiency. If there is cobalamin deficiency, means in the lab value there is a less than 150 cobalamin will be there. So that means it is what? It is B12 deficiency. However, more than 400 suggest adequate cobalamin. So how do you remember this one is? How do you remember means B12, right? B means what? B means B, there is 3 here, right? In the B, suppose if you are writing B like this, B12 like this, then here in place of B there is 3. If you split B, it will become 3. Okay, and 12. This is 1. 3 plus 2 is 5 and 0. B12, right? B12 is 3, 2, 5. These 1 and 1 common, 1, 1, 5, 0. B12 is less than 150. B12 deficiency means less than 150. More than 400 is adequate. So borderline levels are 150 to 400 can be associated with the cobalamin deficiency. So this is the picture: basophilic orthochromic megaloblasts and orthochromic megaloblast in the bone marrow from a patient with the pernicious anemia. Note there is a large size of cells. Open chromatin network is there. See, you can see open chromatin network is there. Open chromatin. Here also open chromatin you can see. And the presence of Howell-Jolly bodies you can observe here. Let me zoom it down for you. Howell-Jolly bodies. In the orthochromic megaloblast, this is orthochromic megaloblast, right? In that orthochromic megaloblast there is Howell-Jolly bodies. These are basophilic. These are all basophilic with a open chromatin. There is large band neutrophil and segmented neutrophil with at least 5 nuclear lobes. Okay, here also band is there, and here is hypersegmented neutrophil is also there. In the second picture, nuclear cytoplasmic asynchrony in the bone marrow. Note the large size of the cells. These are basophilic cells, right? These have become basophilic cells, and large size of the cells are there. Big cells are there. Measurement of erythrocyte folate is not influenced as much by recent dietary changes as is serum folate gives an accurate estimate of average folate levels over preceding several months. On the other hand, if there is a cobalamin deficiency, folate will leak out. If there is a cobalamin deficiency, folate will leak out of the cells, which will give a false low red cell folate and false increased serum folate. So if there is a cobalamin deficiency is there, then folate will leak out. That will give serum folate increased and red cell folate decreased. That is false. In addition, red folate is measured by the folate binding protein assay that rely on the chemiluminescence methodology. These methods show considerable analytic variability. Therefore, the less expensive serum folate measurement is preferred for initial testing. If serum folate is more than 4 nanogram per ml, folate deficiency can be ruled out. It should be more than 4. How you can remember? For folate, more than 4 folate. Early megaloblastic changes can be detected by testing for the methyl malonic acid and homocysteine levels in the blood. So in that patient which I showed you, the case that I have seen where there are more than 7 lobes were there, it was reported as a NNBP. So that patient, 22-year-old female, that patient had these hypersegmented lobes, If it was megaloblastic anemia and it is not showing as anemia, then you can go for, if she is affordable, then you can tell her to get the MMA and homocysteine levels checked. So in this you can see there is variations, so that will give you early megaloblastic changes. Tests for these metabolites are intermediates in folate and cobalamin metabolism and are elevated early in functional vitamin deficiency. Tests for these metabolites are more sensitive than the serum cobalamin levels and increase earlier than a drop in cobalamin levels. By performing tests for both MMA and homocysteine, it is possible to differentiate cobalamin deficiency from the folate deficiency also. So this is important. So rather than going for the B12 levels, if you can check the MMA as well as homocysteine levels, it will give you early window into the megaloblastic anemia before it develops as anemia, as well as it can differentiate between the B12 deficiency and folate deficiency. How beautiful, right? We'll learn how it occurs. Homocysteine is elevated in the folate deficiency, whereas MMA is usually normal. On the other hand, both homocysteine and MMA are elevated in the cobalamin deficiency. See how nicely they have given. Homocysteine is elevated in the folate deficiency. Both MMA and homocysteine and MMA are elevated in the cobalamin deficiency. See, we have tested for the MMA and we have tested for the homo. Homo, if it is increased, then it is folate deficiency. If MMA and homo both are increased, then it is B12 deficiency. If homo is increased, then it is folate deficiency. If MMA and homo both are increased, B for both, you remember, B for both, F for first alphabet, that is homo and MMA. Always you write like this: homo you write first, then MMA you write next, because alphabetically H comes first. So first, when it is elevated, first means F means folate. Both means both homo and MMA, both means B for B12. Easy, right? So there is one flaw in this. If you are writing homo, if you are writing MMA, you can tell B12 also, you can tell cobalamin also. For folate you can tell B9 also, you can tell folate also. So that is very confusing. Generally we will tell folate and B12, right? In that practice I told you this trick. But if you say it has to work universally, then we have to find some other way. An increase in both MMA and homocysteine is also found in combined cobalamin and folate deficiency. In these cases, clinical information is important to help establish a differential diagnosis. A block in the metabolism of histidine to glutamic acid occurs in the folic acid deficiency. Histidine to glutamic acid is blocked, leading to the increased histidine in the folic acid deficiency and cause increased urinary secretion of formiminoglutamate acid. That is FIGLU, an intermediate metabolite. when it is converting from histidine to glutamic acid, there was this intermediate which is called as a figlu. When this is blocked, figlu will be more, so this figlu will be excreted in your urine. This is the sign of B9, that is folate deficiency. After the administration of histidine, so this will happen after the histidine administration. These metabolites return to a normal level when appropriate vitamin is given to the patient. It is recommended that clinicians first use the lower cost test of the serum cobalamin and serum folate to diagnose cobalamin and folate deficiency, and use the higher cost MMA and homocysteine test if cobalamin and folate test results are not definite. First you go for a direct B12 and B9. If it is inconclusive, then go for the homo and MMA. Okay, homocysteine and MMA. Okay, because homocysteine and MMA very costly. B12 also costly, but further more than B12, these are only costly, MMA and homocysteine. The large degree of ineffective erythropoiesis results in a hemolysis in the marrow, and the large degree of ineffective erythropoiesis results in the hemolysis in the marrow and an increase in plasma iron turnover, serum iron, indirect bilirubin, urobilinogen. The characteristic marked increase in the fraction of 1 and 2 serum lactic dehydrogenase is partially caused by the destruction of megaloblast rich in lactic dehydrogenase. So whenever there is megaloblastic anemia, this also finding you can note that there is a increased LD levels, lactate dehydrogenase, because megaloblasts, when they are destroyed, this LD will increase. The increase is roughly proportional to the degree of anemia. So if it is increased 2 folds, LD is increased 2 folds, then HB is also decreased 2 folds. That is anemia increases by 2 folds. Haptoglobin, uric acid, alkaline phosphatase are decreased. Haptoglobin is also decreased, uric acid is decreased, alkaline phosphate is decreased. Additional tests are discussed in the following sections. In the next section, we'll discuss folate deficiency.